Welcome to the Deep Dive. Today, we're dissecting a regulatory event that is, well, it's so profound, it's rewriting 2 decades of women's health policy. I mean, imagine a massive official retraction, a moment when the U.S. government essentially says that blanket warning we issued that created widespread fear around hormone replacement therapy, or HRT, for the last 20 years.
We got the context wrong.
Exactly. We're talking about the systematic dismantling of the broad black box warnings on menopausal HRT products. And for this deep dive, we're relying on a really crucial review by Dr. Reza Lankarani. He's a general surgeon and editorial board member at the Genesis Journal of Surgery and Medicine, and also the founder of the Surgical Pioneering Series. His insights are really going to guide us through this.
And our mission today is to, move beyond the headlines and truly understand the gravity of what the U.S. Department of Health and Human Services and the FDA are doing here. They're actively working with pharmaceutical companies to strip away these class-wide warnings. And this isn't just bureaucratic housekeeping. This is a clear institutional effort to align regulatory policy with what modern clinicians call gold standard science.
So it's a huge shift. Oh, wait. Someone wants to join. Hey, go for it.
Dr. Reza Lankarani. Today I speak to you not just as a surgeon who reviewed this article, but as a physician scientist deeply alarmed by a trend that is undermining every foundation of our profession. I'm referring to the unchecked and misleading of patients, particularly in the New York area, which has become a global export of bad medicine. Being treated like real estate slice decided and sold to the highest bidder with flashy marketing, but with no structural integrity. The focus has shifted from healing to upselling, from proving science to profitable nonsense, often in related cosmetic matters. This is not just an American problem, but a global cancer that often starts at specific influential centers, notably here in New York. This shift is
Yep, go on.
I believe this shift is shameful. The focus has turned away from the life-saving, life-altering core of our science towards commercially driven, cheap tricks designed for getting women. What is happening is profound betrayal, and mostly it's causing irreversible procedures based on social media hype and video promotions, often about labiaplasty and increasing female sexual satisfaction in gynecology. They promises results through injections or surgeries that have no basis or rigorous science. This isn't medicine. This is ethically no different from robbery, taking the worst kind of advantage from someone who
Let's hear it.
places their trust into you. The practitioners behind this are not pioneers, they are profiteers. They operate under false
Go for it.
promises, often with little regard for long-term consequences these patients will face in few years. There are commercials at the most intimate aspects of human health, turning sacred
Yeah, go on.
trust into cheap transaction. This is cheap marketing-based medicine for the world. The most significant disaster is the ripple effect of these unscientific, profit-driven practices, which packaged and exported everywhere, spreading poor standards like a metastatic cancer across the world. The most important disaster we face right now is the erosion of trust. When medicine becomes and the title doctor is used to clock a salesperson, we are all lose. We lose the trust of our patients, we lose the integrity of our research, and we ultimately fail in our primary oath to do no harm. We must return to the core. We must champion evidence, not anecdotes. We must prioritize health, not just appearance. We must be patients first, last and always, and the future of credible, reliable medicine for the entire world depends on it. Thank you for listening.
You are absolutely right. The core of this issue and what you're highlighting is the foundational importance of evidence-based medicine and patient trust.
Okay, let's unpack this. Your point about prioritizing health over mere appearance, especially as medicine becomes commercialized, is directly tied to why this FDA action is so significant.
Exactly. When the science is clear as it now is with the timing of HRT, but that information is distorted by fear, it betrays patient trust and denies actual evidence-based health benefits.
The removal of these warnings is essentially the FDA trying to restore that trust and return to prioritizing patient health outcomes with gold standard science.
And that standard is crucial. Your description of the erosion of trust is powerful, especially when treatments lack rigorous science.
In this case, the FDA is trying to correct the record after 2 decades of widespread fear that denied millions of women real, life-changing benefits.
It's a huge shift, moving away from a generalized fear-based approach and toward nuanced, personalized assessment.
So if you focus as patient health and evidence, we need to solve a kind of medical mystery for you.
What was the singular, flawed piece of evidence that launched 2 decades of fear and misinformation?
Here's where it gets really interesting. The warnings were largely based on one key study from the early 2000s.
That was the Women's Health Initiative, or WHI.
And what's fascinating here is that the WHI involved older women.
Yes, and a hormone formulation that is no longer commonly used today.
The results were generalized to the entire menopausal population.
And that caused the distortion of risk for millions.
So the FDA is now working to remove those broad warnings.
Specifically, references to the risks of cardiovascular disease, breast cancer, and probable dementia are being removed.
This removal signals an official acknowledgement that the risks are much lower than initially feared.
Especially for healthy women starting treatment earlier within that 10-year window of menopause onset.
This moves us toward more personalized care and truly prioritizing the patient first.
And returning to solid, evidence-based recommendations.
A huge shift in women's health policy and trust.
We must keep championing evidence over anecdote.
Dr. Lankarani brings a unique perspective to this.
He really does. He's a practicing general surgeon, which is key, but also the founder of the Surgical Pioneering newsletter and podcast series.
And vitally for our discussion today, he's an editorial board member of the very journal we're focusing on.
The Genesis Journal of Surgery and Medicine, GJSM.
That's the one. So he sees it from multiple angles, clinician, educator, editor.
It gives him this really valuable sort of inside-out view of what makes a medical journal truly impactful today. And the vision and its architect, driving surgical and medical advancement. Talk to me about Dr. Lankarani's personal commitment here.
Well, his review makes it pretty clear. As a newer editorial board member, he brings this fresh perspective, but it's deeply rooted in his own work.
The surgical innovation, the education side?
Precisely. He's dedicated to advancing surgery through research, education, and multidisciplinary collaboration. That last part is key.
And his experience with the Surgical Pioneering newsletter and podcast, that must give him a unique view on communication platforms.
Absolutely. He's not just seeing journals as static repositories. He understands how knowledge needs to be disseminated dynamically in the digital age. He's actively shaping that conversation.
And how does he frame his role with GJSM?
He actually calls it an honor to introduce his editorial. He sees it as a celebration, his words, a celebration of the journal's unwavering commitment to advancing global medical knowledge.
So it's not just a position, it's a mission for him.
It really seems that way. It feels personal. His background as a practicing surgeon, combined with his digital education work, gives him this really comprehensive grasp of what makes an academic platform genuinely impactful and accessible now.
He sees GJSM as more than just a place to publish papers.
Exactly, as a vital conduit for progressive practical knowledge, the kind that actually improves patient care in the real world.
That personal investment, it definitely comes across. And it's tied to these core principles he highlights for GJSM: rigor, inclusivity, and innovation. These aren't just buzzwords, are they? How do they actually make these foundational?
That's the million-dollar question, isn't it?
Yeah.
There's lots of journals say these things. For GJSM, rigor seems to mean this relentless focus on scientific soundness, methodological integrity.
So strong peer review, obviously.
Strong peer review, yes, but also fostering a culture where every claim is meticulously checked. So for you, the listener, reading GJSM means you can, trust the data, you're getting vetted info.
Okay, and inclusivity.
Inclusivity is about making sure diverse perspectives get heard. Solutions from, say, underrepresented regions or disciplines. It's not just about fairness, it's strategic. Well, medical challenges aren't uniform globally, right? A solution from a top U.S. hospital might be totally useless in a rural clinic somewhere else. Inclusivity means you hear from everywhere. You get a truly holistic picture.
It prevents blind spots.
Exactly. And then innovation is the engine. Not just publishing the latest gadget or technique, but fostering novel thinking, interdisciplinary approaches, research that pushes boundaries.
So GJSM is actively looking for the next big thing.
Seems like it. They want the ideas that will shape tomorrow's healthcare. So for you, this means access to knowledge that's accurate, comprehensive, and globally informed, critically relevant, pushing the envelope.
It affects the quality and the breadth of information available.
Directly.
And Dr. Lankarani frames GJSM as reflecting the collective aspirations of our international community. What's the significance of building that shared purpose?
Well, zooming out a bit, it suggests they're building more than a journal. They're building a community.
Based on trust and these shared values.
Right. When researchers from all over choose GJSM, they're not just picking a place to publish. They're aligning with rigor, inclusivity, innovation.
It creates a collaborative vibe.
That's the idea. A hub where minds connect, share, inspire each other, breaking down those old silos between specialties, between countries.
And that ultimately benefits patients.
That's the goal. Accelerating discovery on a global scale. An ecosystem where knowledge doesn't just sit there, it grows, it transforms.
Okay, that makes sense. Let's move to section 2. This idea of a global mosaic of expertise breaking down borders and scholarship. This international editorial leadership sounds really interesting.
It really is. And Dr. Lankarani highlights it as perhaps GJSM's most striking strength. It's deliberate.
Not just accidental representation.
No, it seems very intentional. The editor-in-chief, Jeffrey D. Gross, is from the USA, but the board itself, it's a genuinely global brain trust.
How global are we talking?
We're talking over 15 countries, spanning 6 continents. You've got leading figures like Propi Yopi Afriandi Habibi from Indonesia, Dr. Borouj Noureddin from Algeria, Professor Adel Ecladius in Australia, Dr. Lu Wei from China,
Wow.
and many others. Germany, Canada, UK, Egypt, Saudi Arabia, Turkey, Sudan, Venezuela, Kuwait, India, Brazil, Uruguay, Argentina. The list goes on. It ensures a breadth of perspective that's frankly quite rare.
First, what was the singular flawed piece of evidence that launched 2 decades of fear and misinformation?
Right.
Second, what is the new nuanced scientific principle, this thing called the timing hypothesis, that replaces that fear?
Right.
And finally, what does this all mean for the millions of women worldwide who've been hesitant or even outright denied effective care?
Okay, let's unpack that, starting at the source of all the caution.
Yeah.
Before we get into why the warning was removed, let's define the tool itself. When we say a black box warning or a boxed warning, what exactly are we talking about, and why is getting rid of one such a seismic event?
A boxed warning is, simply put, the FDA's most aggressive tool for caution. It is the absolute strongest safety alert they can legally mandate for a prescription drug.
The strongest.
The strongest. Its entire purpose is to force physicians and patients to pay immediate, unavoidable attention to risks that are serious, life-threatening, or...
Potentially fatal.
Exactly. Potentially fatal.
So it sounds like a literal signpost just screaming danger.
It is, both visually and legally. It's a statement inside a thick black border placed right at the top of the product information insert.
We can't miss it.
You cannot miss it. And its presence carries a significant legal and ethical weight for the physician.
So what was the practical implication of having that specific, terrifying warning attached to HRT? What did it force doctors to do? And maybe more importantly, what did it scare them into not doing?
Well, its presence created a massive chilling effect. The official mandate for providers was to apply extreme clinical judgment, conduct rigorous patient selection, and have these highly transparent risk-benefit discussions.
Which sounds reasonable on paper.
It does, but what happened in reality was much simpler. Avoidance. The black box broadly highlighted serious risks, cardiovascular events like stroke, breast cancer, probable dementia.
All the big ones.
All the big ones. And because of the liability and the overwhelming fear tied to that black border, many primary care physicians they stopped prescribing HRT altogether, even for women who were perfect candidates.
Wow.
So for 2 decades, this blanket warning inadvertently became this powerful form of misinformation. It fueled a narrative of generalized risk that caused millions of women who genuinely needed the therapy to be denied access.
That denial of care based on a regulatory caution, I mean, that's the real human cost here, isn't it? So removing this barrier, it's more than just regulatory pruning. It's a huge push toward destigmatization.
Absolutely. The removal signals to the entire medical establishment that we are moving away from a broad fear-based system. We're shifting toward nuanced, personalized guidance based on modern, robust data. And this opens the door for you to have an open, evidence-based conversation with your healthcare provider without that shadow of institutionalized fear hanging over the whole discussion.
Okay, so this is where we get to the core of the medical mystery. The root of that 2-decade fear storm was this study, the Women's Health Initiative, the WHI, from the early 2000s. Officials are now openly saying that study provided misleading context. So help us understand why. Why is the WHI now considered so flawed? What skewed its risk data so severely?
The WHI was, it was massive and groundbreaking in its day, but it had two critical design limitations that completely distorted its application to the average menopausal woman.
Okay, what's the first one?
First, the women they recruited were not the typical population seeking HRT. The average age of participants was about 63.
63. So often a full decade or more past the onset of menopause.
Exactly. And that age difference is key because many of these women had already accumulated significant baseline health risks, things like subclinical cardiovascular disease, hypertension, early arterial plaque. So if you introduce hormones later in life, when those diseases are already kind of simmering under the surface, the hormones can behave very differently than if you introduce them early.
Right, so you're starting with a population that's already at a higher intrinsic risk for heart attack or stroke. So any bad outcomes are going to look like they were caused by the hormone treatment.
Precisely.
Even if the treatment just, tipped over a domino that was already wobbling.
That's a great way to put it. And the second major flaw was the formulation itself. The study relied mainly on a hormone combination using conjugated equine estrogens, often with a synthetic progestin.
A type of hormone that was common then, but not so much now.
Not at all. It's not the nuanced, individualized, often bioidentical focused approach that many clinicians use today. So the FDA's initial reaction to the WHI results, to just slap the maximum boxed warning on everything, was a huge overgeneralization.
So they took data from older women with more health risks using an older formula.
And they inaccurately applied it to every single woman entering menopause, no matter her age or what specific formulation she might use.
That is a colossal failure of context.
Yeah.
It's actually shocking that generalized data could cause such widespread clinical avoidance.
It is. The official sentiment you see cited in the source material is powerful. It says millions of women have been denied the life-changing benefits of HRT due to a distortion of risk.
That tells you everything. The fear was completely out of proportion to the actual risk for most of the population.
It absolutely was. The key insight here is that the WHI measured risk in a population where risk was already amplified by time and disease. Modern science, which the FDA is finally embracing, measures the protective potential of starting therapy earlier.
Which brings us to the scientific engine driving this whole policy change. The timing hypothesis. This isn't just some convenient excuse, right? This is a core scientific principle. What is it, and how does it rewrite the risk equation?
The timing hypothesis is actually elegant in its simplicity. It just asserts that the risk-to-benefit ratio of hormone therapy is overwhelmingly dependent on when a woman starts it.
When?
Specifically, how close she is to the actual onset of menopause. We're talking about a critical biological window.
A window. Okay, so what's the science behind that?
It relates directly to vascular health to your arteries. If you introduce systemic estrogen early, when the arteries are still healthy and pliable and free of significant plaque, the hormones can actually be protective. They promote vasodilation and help keep vessels clear.
Okay.
But if you introduce them late, after plaques and damage are already there, the hormones can potentially make things worse, maybe by exacerbating inflammation or even disrupting those established plaques.
So it's not the hormone that's the danger, it's the timing relative to the state of the underlying disease.
Exactly right. It's the difference between doing preventative maintenance on your car versus trying to fix a decades-old problem with the wrong tool.
That's a great analogy.
And this hypothesis translates directly into the new evidence-based gold standard for recommendation. Initiating systemic HRT within 10 years of menopause onset or before 60 years of age. That's the window.
That window under 60 or within 10 years, that seems to be the crucial piece of knowledge we need you to walk away with. So what are the specific evidence-based benefits for women who start therapy inside that sweet spot?
The research that's been generated since the WHI, focusing specifically on this optimal window, it reveals profound benefits. Critically, we see a reduction in all-cause mortality.
A reduction in dying from anything.
Right. In other words, for healthy women who start early, they are living longer, healthier lives overall.
And what about the specific things the black box warned against?
Well, beyond longevity, the benefits are focused heavily on those very systems. We see major positive impacts on cardiovascular health, a lower risk of cardiovascular diseases as long as treatment is initiated early, and significant gains in bone health, which means a reduced risk of bone fractures. And that's a massive public health concern for aging women.
And I remember the source review also mentioned protective effects on the brain, which is something you don't always hear about in this discussion.
That's right. Neuroprotection is a critical piece of this puzzle. There is strong evidence linking early initiated HRT to a lower risk of Alzheimer's disease.
Wow.
The totality of the evidence now clearly supports that starting therapy within that optimal biological window provides profound systemic protective health benefits that were just completely obscured by the flawed WHI data.
All right, let's shift now to the regulatory specifics, the hard facts. What is actually being removed from the labels? And maybe just as importantly, what specific warning is staying? Because this isn't a blanket all clear, is it?
Not at all. The FDA is targeting the warnings that stem directly from the generalized fears of the WHI. So they are actively working with drug manufacturers to remove or severely diminish the generalized references to the risks of cardiovascular disease, breast cancer, and probable dementia.
So removing the main pillars of that previous broad condemnation.
Exactly. However, the policy shift maintains a level of clinical prudence. One crucial warning remains. The boxed warning for endometrial cancer on systemic estrogen-alone products is not being removed.
Okay, help us understand that distinction. Why keep the endometrial cancer warning but get rid of the others?
Because the risk of endometrial cancer, which is cancer of the lining of the uterus, is still a very clinically significant and genuine risk for women who take systemic estrogen therapy alone while they still have a uterus.
Right.
Estrogen causes the uterine lining to proliferate, to grow. And if that's unopposed, that proliferation can become uncontrolled and potentially cancerous.
But there's a way to manage that risk.
The key distinction here, and this really gets to the nuance of modern personalized medicine, is that this risk is almost entirely preventable. If you have a uterus and are taking systemic estrogen, you must also take progesterone. The progesterone counteracts that proliferation. So by keeping this specific black box, the FDA is highlighting that we are replacing generalized fear with precise, personalized risk management.
So the conversation shifts from, are hormones risky, to which hormone combination is safe for my specific body?
That's it exactly. It's a perfect illustration of the move from a blanket policy to personalized medicine.
Now, beyond just pruning these regulations, the FDA also took action to increase treatment availability at the same time. What other options did they approve?
Yeah, to expand access and choice, they made two other important announcements. First, they're approving a generic version of Premarin, which is a very widely known conjugated estrogens product.
And that's a huge win for accessibility, for cost.
It's a huge win. It'll make HRT more affordable for potentially millions of women.
And the second thing?
Second, and this is equally important for women who fall outside that optimal window or who have contraindications to hormones, the FDA approved a new non-hormonal treatment option. This medication is specifically designed to manage moderate to severe vasomotor symptoms.
Which are those debilitating high flashes and night sweats.
Exactly. So this ensures that even women for whom HRT isn't the right fit still have a highly effective alternative.
So what does this all mean for you, the listener? I mean, the removal of the black box warning marks this massive policy pivot. It replaces generalized fear and medical avoidance with precise, evidence-based guidance tied directly to your biological clock. Is an official institutional acknowledgement that for healthy women starting treatment within that optimal window, under 60 or within 10 years of their last period, the documented benefits of reduction in mortality, fracture risk, and cardiovascular protection often significantly outweigh the generalized risks highlighted by that single outdated study.
And this shift is so crucial because it aligns regulatory policy with overwhelming scientific consensus. It forces the medical community to practice according to the timing hypothesis, which, it raises an important question for all of us. If the misinterpretation of a single decades-old study could distort medical perception, prescribing practice, and regulatory guidelines for 20 years, leading to the systematic denial of effective care for millions, what other areas of medicine are currently operating under outdated, generalized guidelines that are in desperate need of this kind of official, comprehensive revision and course correction?
That is a truly fascinating thought, that sometimes medical progress isn't about discovery, but about officially correcting the record on past mistakes. Thank you for providing such a detailed look into this. It's really complex. This deep dive was based on a fascinating review by Dr. Reza Lankarani, who is an editorial board member at the Genesis Journal of Surgery and Medicine. To access additional details, please refer to the Surgical Pioneering Podcast Series application. It's available at the following link: Surgical Pioneering Podcast, or on most of the well-known podcast applications and platforms. We highly encourage you to explore the original source material. We'll see you next time on The Deep Dive.